Chapter 2, Principles of Pharmacology. We'll skip over the key terms because we will cover them throughout the chapter. The word pharmacokinetics is derived from the Greek words pharmako, which means drug, and kinesis, which means movement. There are 4 pharmacokinetic phases. They are absorption, distribution, metabolism, and elimination. We abbreviate those as ADME. Drugs that are administered must be absorbed into the bloodstream and distributed to their site of action before they can begin to produce their effect. The body metabolizes the drug and then it is eliminated. As the drug moves throughout the body, it undergoes changes that may increase or decrease its absorption, distribution, metabolism, or elimination. These pharmacokinetic phases control the intensity of the drug's effect and the duration of the drug's action. So figure 2.1 goes through the phases of drug distribution. And again, a good way to remember the order of the pharmacokinetic phases is to use the acronym ADME. The length of time it takes for a drug action to begin after a dose is administered is called the onset of action. The onset of action is not achieved until the drug reaches the minimum concentration in the body needed to produce the drug action. The maximum drug effect or peak effect occurs after the maximum drug concentration of the drug is reached in the body. The duration of action is the time between the onset of action and the discontinuation of the drug action. The duration of action is the amount of time the drug concentration remains within the therapeutic range. Figure 2.2 shows onset of action, peak effect, duration of action, and therapeutic effect. So you can kind of see what they mean by that. Absorption is the first pharmacokinetic phase. Absorption is the process that involves the movement of drug molecules from the site of administration across cell membranes, and into the circulatory system of the body. Absorption may occur across the skin or cells that line the blood vessels. How quickly or slowly a drug is absorbed is determined by the characteristics of the drug dosage form, the route of administration, human anatomy, and physiology. The amount of drug absorbed is also influenced by many factors. Absorption of tablets and capsules that have been swallowed does not begin until after the drug goes into solution, so factors affecting disintegration or dissolution of the drug can decrease absorption. Absorption of drugs taken by mouth may also be delayed when food is present in the stomach. The ease with which the drug is able to cross the cell membranes is a factor with how readily the drug is absorbed via oral, rectal, vaginal, and other routes of administration. Drug movement from the site of administration into the circulatory system depends on the ability of the drug to move across cell membranes. The cell membrane is a complex structure of lipids, proteins, and water-filled channels. Caffeine, vitamin C, vitamin B, niacin, and ephedrine are examples of drugs that pass through the aqueous channels in the cell membranes. Figure 2.3 shows a picture of the plasma membrane. Drug absorption across the cell membrane may occur via passive or active transport mechanisms. Drugs that are absorbed by passive diffusion move from a region of greater concentration to a region of lesser concentration. When the drug first enters the body, the concentration at the administration site is greater than in the bloodstream. Lipid-soluble drugs readily diffuse across the cell membrane of the blood vessel into the bloodstream. Lipid-soluble drugs are lipophilic, lipid-loving, and hydrophobic or water-hating. Water-soluble drugs are hydrophilic or water-loving and move through the small water channels in the cell membrane. Most drugs are transported via passive transport. Active transport mechanisms permit the drug to move across cell membranes without regard to concentration. A drug can move from an area where drug concentration is low to an area where the concentration is high. Active transport takes energy and requires special carrier proteins or pumps to carry the drug across the cell membrane. Most drugs are either weak acids or weak bases. In solution, weak acids and weak bases exist between the ionized and the non-ionized state. In solution, weak acids dissociate, releasing a proton and negatively charged anion. Weakly acidic drugs are more ionized when they are in basic solutions. When the drugs are in an acidic solution, they are less ionized. Weakly basic drugs are more ionized when they are in acidic solution and less ionized in basic solution. This is important because as the drug travels throughout the body, it passes through acidic solutions like in the stomach and basic solutions in the small intestine. The ability of a drug to diffuse across the cell membrane depends on properties of the drug and the pH of the body fluid in which it is dissolved. Intravenous solutions that contain electrolytes in concentrations similar to those of plasma are called crystalloids. Diffusion across the cell membrane is greatest when the drug is lipid soluble and non-ionized. When a weakly acidic acid drug such as phenobarbital is in the stomach, it is less ionized and can readily cross the cell membrane. Absorption is high when the drug moves into the small intestine. Ionization increases and absorption is reduced. Osmosis is the movement of water across a semi-permeable membrane from a higher to lower concentration. Electrolytes are more concentrated inside the outside of the cells, and the water outside the cells is less concentrated or dilute because it contains fewer electrolytes. Absorption is greatest in areas of the body that have a good blood supply. Medications administered sublingually have good absorption because many blood vessels are located under the tongue. Absorption of orally administered drugs is greatest in the small intestine. The structure of the intestine is designed to perform the specialized job of absorption. Thousands of microvilli line the walls of the small intestine. The microvilli are filled with blood vessels. As the drug passes through the cell membrane of the microvilli, it is quickly absorbed into the bloodstream. Absorption of drugs that are injected intramuscularly or subcutaneously is increased when the patient applies heat to the muscle, exercises, or does some other activity to stimulate blood flow to the site of administration. Microvilli also increase the surface area of the small intestine, making it the largest absorbing surface in the body. The area for absorption is the small intestine, is approximately 1,000 times greater than in the stomach. Oops. So you can see here in figure 2.4, intestinal villi showing absorbing surfaces. So here is the microvilli on the outside. That is increasing the surface area. And then you can see here the capillaries. Drug absorption increases the longer the drug is in contact with the absorbing surface. Drug absorption is decreased if the patient has diarrhea because of the rapid passage of contents through the GI tract. Absorption of delayed release drugs can be increased when a drug is taken with food because of delayed gastric emptying. Drug absorption is greater across single cell membranes than multiple cell layers because some drugs may become trapped in cell layers. As tissue thickness increases, the portion of the drug trapped in the cell layers increases as well. Distribution is the process of movement of the drug from the circulatory system across barrier membranes to the site of drug action. It is the second pharmacokinetic phase. Figure 2.5 is just depicts distribution from a drug. It's kind of an interesting and nice little chart to kind of understand what's happening. Extracellular fluid consists mainly of the plasma found in the blood vessels and the interstitial fluid that surrounds the cells. Intracellular fluid refers to the water inside the cells. Sodium, potassium, and chloride are major electrolytes found in the body. Sodium is the major positive ion in extracellular fluid. Sodium regulates the total amount of water in the body and the transmission of sodium into and out of the individual cells. It plays a role in critical processes in the brain, nervous system, and muscles that require electrical signals for communication. Potassium is the other major cation found inside of cells. The proper level of potassium is essential for normal cell function. Regulation of the heartbeat and muscle contraction are two important functions of potassium. Chloride is the major anion, which an anion is a negatively charged ion, found in the fluid outside of cells and in the blood. So one thing to remember is 0.9% sodium chloride, which is NaCl, is also known as normal saline because it is the same concentration as in the body. So whenever you see 0.9% sodium chloride, that's normal saline, and half of that is 0.45% sodium chloride, which is 1/2 normal saline. The distribution of a drug across the blood vessel cell membrane and transport to its site of action are influenced by the chemical nature of the drug, such as lipid solubility. Drugs that are lipid soluble, non-ionized, or sized small enough to pass through slit junctions in the capillary wall are readily distributed. The blood contains albumin, a plasma protein. Many drugs have an affinity for albumin and bind reversible to the protein. When the drug is bound to plasma proteins, it is unable to move out of the blood vessels to get to the site of drug action. Colloids, proteins, or other large molecules that are too large to cross membranes remain suspended in the blood for a long period of time. Plasma proteins act like a drug reservoir for the bound drug trapped within the blood cells. As the concentration of unbound or free drug decreases in the bloodstream, the drug that is bound to the plasma protein is released and transported to the site of action. When two drugs are administered that both have an affinity for plasma albumin, the drug with the greatest affinity will competitively bind to the protein. Albumin has the greatest affinity for weak acids and hydrophobic drugs. The competition for albumin binding can result in the release of bound drug, enabling it to get to its site of action. Severe burns can decrease plasma protein levels, which may alter the level of free drug. Competitive protein binding represents a mechanism for drug interactions. Figure 2.6 shows protein binding and free fraction of drugs. Natural body barriers may limit access to the site of drug action. The anatomic structures that selectively limit drug access are the blood-brain barrier, blood placenta barrier, and blood testicular barrier. The blood-brain barrier is composed of cells lining the capillaries of the brain that form tight junctions. The blood vessels in the brain are also surrounded by fatty structures called glial feet, also known as astrocyte foot processes. These structures limit the passage of ions between the capillaries and brain tissue. They permit passage of lipid-soluble hydrophobic drugs into the brain and limit access of ionized hydrophilic drugs. So figure 2.7 shows the different barriers. The blood placenta barrier limits access of drugs taken by pregnant women to the fetus. However, many drugs are able to cross the blood placenta barrier. So it is important for pregnant women to ask their physicians or pharmacists about potential safety issues before taking a drug. Prior to 2015, drugs were classified into 5 pregnancy safety categories. A, B, C, D, and X. Drugs classified in pregnancy safety category A were shown to be safe when taken during pregnancy. Fetal abnormalities were reported in drugs listed in category X. In 2015, the FDA replaced the system of classification. New rules require manufacturers to include a summary of the drug's risks if taken during pregnancy and lactation, description of data supporting the drug summary, information to aid in counseling of pregnant women and healthcare provider prescribing. Few drugs that are administered are eliminated unchanged. Most drugs are transformed by enzymes to a metabolite. Biotransformation is the process of drug metabolism in the body that transforms a drug to a more active, equally active, or inactive metabolite. The primary site of biotransformation is the liver. However, metabolism may occur in the intestines, lung, kidney, or other cells in the body. Microsomal enzymes in the liver are responsible for transforming lipophilic drugs to compounds that can be more easily eliminated by the kidney. The cytochrome P450 system is frequently involved in this process. Drugs that interfere with the enzymes of the CYP450 system can enhance or inhibit the metabolism of other drugs that are taken concurrently. So not all drugs are metabolized to inactive metabolites. Table 2.1 shows products of metabolism. So for example, the parent drug, prednisolone, the metabolite, the equally active drug is prednisone. Prodrugs are drugs that are administered in an inactive form and must be metabolized to their active form. Drugs may be formulated as prodrugs to avoid side effects or to increase distribution to the site of action. Levodopa is a prodrug that is metabolized to dopamine in the brain. The drug is used to treat Parkinson's disease. Levodopa is able to cross the blood-brain barrier better than dopamine. Administration of the prodrug increases the volume of drug distributed into the brain. Orally administered drugs must pass into the hepatoportal circulation before entering the general circulation. The first pass effect is a process whereby only a fraction of an orally administered drug reaches the systemic circulation. Much of the drug is metabolized in the liver to an inactive metabolite before passing into the general circulation. Figure 2.8 shows the first pass effect. When metabolism is increased, the duration of effect of many drugs is reduced except prodrugs, for which the onset of drug action begins with metabolism. The liver is the primary site for metabolism. If the liver is functioning below capacity, metabolism is decreased. Drug doses are often to be reduced in the presence of liver dysfunction. Diseases such as hepatitis decrease the metabolic capacity of the liver. Lung diseases and kidney disease can also reduce the ability of the body to metabolize drugs. Heart failure decreases blood flow to the liver, altering the extent of drug metabolism. Metabolism in the liver is decreased in elderly adults and in infants. Age-related changes in the liver decrease metabolic enzyme functions in elderly adults. Metabolizing enzyme systems, CYP450, are not fully developed in infants, therefore their ability to metabolize drugs is decreased. Infants and elderly adults generally require lower doses of drugs to produce therapeutic effects. Administration of two or more drugs that both use the same metabolic pathways can alter the metabolism of each other. CYP450 isoform substrates are a large group of metabolic enzymes. The metabolism of many drugs is altered by the co-administration of CYP450 substrate inducers or inhibitors. Enzyme inducer substrate binding increases metabolic enzyme activity, and enzyme inhibitor substrate binding decreases metabolic enzyme activity. A genetic deficiency of a metabolic enzyme can reduce the body's ability to metabolize drugs that use the enzyme. NutraSweet is a common sweetener found in diet, foods, and beverages. It is the derivative of the amino acid phenylalanine. People diagnosed with the disorder phenylketonuria lack the enzyme needed to metabolize the amino acid phenylalanine to tyrosine. If they consume products containing aspartame, then they may build up toxic levels of phenylalanine. Metabolism is decreased when nutritional status is severely depressed, as in starvation. Low protein diets and diets deficient in essential fatty acids can reduce the synthesis of drug metabolizing enzymes and decrease metabolism. Deficiencies of vitamins and minerals can affect metabolism because they catalyze biochemical reactions in the body. For example, vitamin B2 catalyzes oxidation reduction reactions. Oxidation and reduction are metabolic processes that result in drug inactivation. The rate of metabolism of some drugs varies between men and women, suggesting the sex hormones may influence metabolism. Men metabolize propranolol, a heart drug, faster than women do. Women metabolize acetaminophen and analgesic slightly faster than men do. Elimination is the final pharmacokinetic phase. Elimination results in removal of the drug from the body and discontinuation of drug action. The three major routes of drug elimination are the kidney, lung, and bowel. Table 2.3 shows routes of drug elimination and where they're eliminated to. So in the kidney, they're eliminated in urine. In the lung, they're eliminated in expired air. In the bowel, feces. So those are the major. And the minor for the liver, bile, skin, sweat, eyes, tears, mouth, saliva, nose, mucus, penis, semen, and breast milk. The normal function of the kidney is to filter the blood and remove things that are foreign or harmful. This job is done by the nephrons of the kidney. Free drug, which is not bound to albumin, is transported to Bowman capsule where it is filtered by the glomerulus. As the drug moves through the nephron to the distal convoluted tubule, its concentration increases. If the drug is non-ionized, it may diffuse out of the nephron back into the systemic circulation and continue to produce drug action. When the drug is ionized, elimination in the urine is increased. Kidney dysfunction can have a profound effect on elimination of drugs from the body. Decreased kidney function decreases the extent of drug cleared and the rate of clearance. This can cause a buildup of drug in the body and produce toxic drug effects. Changes in the acidity of the urine can influence the rate in which a drug is cleared from the body. Weakly acidic drugs are less ionized in acidic urine. As the pH of the urine becomes more basic, the ionization of acidic drugs increases. Lung, kidney, and bowel disease decrease the body's capacity to eliminate drugs and their metabolites. Bowel disease may increase or decrease elimination. Crohn's disease causes excessive diarrhea, which speeds up the elimination of drugs. When movement of contents of the bowel is slowed, drug elimination is delayed. Lung diseases such as chronic obstructive pulmonary disease decrease elimination in expired air. Drug interactions can result in increase or decrease elimination of drugs. Pharmacists and healthcare providers may purposely recommend concurrent administration of two drugs to delay elimination and prolong drug action or to speed elimination. Elimination half-life refers to the time it takes for 50% of the drug to be cleared from the bloodstream. It takes approximately 8 half-lives to entirely eliminate a drug from the body. Every drug has a unique half-life that is dependent on characteristics of the drugs, like active metabolites. Knowledge of elimination half-life is important. It is an indicator of how long a drug will produce effects in the body. The half-life of a drug can be as short as a few minutes or as long as several days. Drugs with long half-lives are dosed less frequency than are drugs with very short half-lives. Bioavailability is defined as the rate and extent to which the active ingredient of an administered drug enters the systemic circulation, reaches the site of action, and is available to produce its effect. The bioavailability of a drug is influenced by drug absorption, the first pass effect, and distribution to the site of action. The bioavailability of generic drugs is compared with the innovator's product to determine if the generic is bioequivalent. Bioavailability tests are conducted to determine if the generic drug achieves the same maximum blood concentration in the same time as the brand name drug. The generic is bioequivalent if no statistical differences are found in the rate and extent of absorption when the drug is administered in the same strength, dosage form, and route of administration as the brand name product. Pharmaceutical equivalents differ from bioequivalents. Bioequivalent drugs and pharmaceutical equivalent drugs both contain the same active ingredient and the same strength as the innovator's drug, the brand name. Pharmaceutical equivalents may have different inactive ingredients, be manufactured in a different dosage form, and exhibit different rates of absorption than the brand name. Pharmaceutical alternatives contain the same active ingredient as the brand name product. However, the strength and dosage form may be different. A therapeutic alternative may contain the same desired therapeutic outcome but have different active ingredients.